Hi, this is Brian Kim. I'm going to share with you this very interesting case referred to me. This was a Morgagnian cataract, not a cataract, a Catarock with fibrotic anterior capsule and severe zonulopathy. You'll see the things that I did to try to get through this case, the things I could have done better, and despite all the challenges of the cases, how I was able to get a successful outcome. I use a corneal mark to help me center and size my rexus. I make my paracenteses incisions and inject intracameral lidocaine and epinephrine. I inject some intracameral air and then paint the anterior capsular surface with trypan blue. You can see despite a retrobulbar block, the patient's eye is pointed downward. But despite this, I'm able to use the paint roller effect and paint the entire anterior capsule surface with the trypan. I inject dispersive viscoelastic to fill the anterior chamber. And then I do my triplanar corneal incision. I make a vertical groove and then tunnel and then enter the anterior chamber. I'm using a 25 gauge needle to do my puncture rexus. I puncture the central capsule. You can see there's significant stria as I puncture, and then I'm evacuating the bag of the lens material, and lo and behold, the entire bag was just filled with milk. And this is just a dense, solid 8 millimeter or larger Catarock. I'm trying to use a needle to kind of push on the capsule. You can see there's significant zonulopathy, and despite using the needle, there is no movement of the anterior capsular rexus whatsoever. It's just pulling and creating a lot of tension on the zonules and the capsule. I switched to a cystotome needle, and this is equally futile. I'm trying to push and push, and you can see all those strias in the zonules. I'm using my rexus forceps, and again, I'm having the same result, no movement of the capsular rexus due to the significant zonulopathy. I'm using a Maltzman for counter force, and I'm going to slip the Maltzman through the anterior capsule opening, and I'm providing counter traction as I pull for my rexus. But I'm realizing it's not only just zonulopathy, it is also the patient has significant anterior capsule fibrosis, and that's why the capsule won't move. And so I use intraocular scissors to create another flap. And again, despite this, I'm able to create a little bit of a flap, but again, there's significant zonular weakness. You can see there's significant stria in the capsule. And because of the fibrosis, I'm not able to propagate an appropriate capsulotomy. I struggle to continue to make my rexus. I use the cystotome again to see if I can create another puncture. You can see there's significant zonular stress when I do that, but ultimately I'm able to create a capsulotomy. However, it is extremely small. Getting to this very end, I was not able to complete the capsulotomy due to significant fibrosis and stria, and so I had to use scissors again. I'm going to do my hydrodissection, but as you can tell, the lens is wobbling around and jumping around like a pinball in a pinball machine. But as I'm doing this, I'm learning that there's significant adhesions between the lens and the anterior capsule. And then I'm trying to go under the lens, and I can appreciate there's not only adhesions between the capsular bag and the anterior side, but there's also adhesions on the posterior side. I try once again to see if I can extend and enlarge my capsulotomy, and I was not able to do it. And so you will see that single nick that I made in the anterior capsule to see if I can widen my capsulotomy was my near fatal mistake. I tried to grab the lens. I'm trying to do some type of chop maneuver. I don't want to sculpt because that lens is freely mobile in the bag. There is absolutely no cortex, no epinucleus. There is absolutely nothing that's protecting me between the phaco-tip and the posterior capsule. Any wrong movement, and I will rupture the capsule very easily. Again, there's significant zonular disease. There's no peripheral capsule support from the zonules, and I have this fibrotic anterior capsule. So I thought, okay, I have a fairly fibrotic anterior capsule. Maybe it'll withstand my forces as I try to chop this lens. And so I tried to impale the lens a little bit, and I sandwich the lens and I try to crush it. And lo and behold, you can see I have an anterior capsular rent in the same spot where I tried to use my scissors in order to enlarge my capsulotomy. So I go ahead and stop, push some more viscoelastic in the eye before I withdraw the phaco-tip. I decided at this point to do a can opener capsulotomy. I'm using my cystotome, and I want to thank Dr. Glenn Smalley and his team in Jamaica. I went on an M6 mission trip with them, and I got really, really good at doing my capsulotomy with the can opener technique. I think younger and younger surgeons coming out have less and less experience doing extra caps and manual small incision cataract surgery. I think doing a can opener style capsulotomy like I'm doing now is an important step to learn. You do the capsulotomy with a can opener. The idea is you're creating multiple weak points in the capsule. So when you try to prolapse this lens out, you won't have a radialization of the tear. You see that single tear that I have, it's not to the equator yet. It's only in the anterior capsular rim. But by doing the can opener technique, you're able to minimize any direct trauma and tension on the weak area so that it won't have a wraparound. So I'm going to go ahead and use some dispersive viscoelastic. I'm going above the lens and under the lens. And as I'm doing this, I can appreciate there's significant adhesions, again, between the lens and the posterior capsule. So I'm doing pretty aggressive visco dissection of the lens to separate it from the posterior capsule. I'm very gently trying to tease the lens up and making sure that there are no more adhesions on the lens. You can see I'm doing a spinning technique. Again, something that I learned when I was in Jamaica on my M6 trip. This ensures that the lens is completely free and not adherent to the capsular bag. This little carouseling of the lens, but I'm also trying to tease the lens up, and you can see I'm having trouble teasing the lens up and out of the bag. And so this really saved me. I have a reverse Sinskey hook for my DSEC cases, and I decided to use the reverse Sinskey hook to grab the lens from underneath, and then I was able to pull the lens up into the anterior chamber, and it just worked marvelously. I go ahead and widen my incision using my 1mm paracentesis blade, inject more viscoelastic above and below the lens, go in with a lens loop, and make sure that the lens loop is not snagging the posterior capsule. You want to just go right underneath the lens, and then I'm going to use some 0.12 forceps. I'm going to lift the roof of the incision, and then I'm going to push down slightly. You don't want to scrape the lens against the corneal endothelium. And as I lift it, I'm pushing down slightly, and you can see I was able to deliver the lens. I'm keeping the lens loop there very carefully because you don't want to accidentally take the posterior capsule with you or the iris. And I learned this again in Jamaica, and you want to gently tease out the lens, and I was able to see that the bag was still intact, and the iris was also not incarcerated in the wound, because if you pull that out, you can actually tear the iris root in the process. I'm placing my corneal incision sutures and then delivering the single piece acrylic intraocular lens into the capsular bag. I'm going to be very careful and make sure that I turn the haptic so the haptic is not pointed towards the anterior capsular rent. And I can see that because I only have a few sutures here, if I go in with the INA, it's going to cause significant iris prolapse. And as a result, I decided to put in a total of 5 sutures, 5 interrupted tendonolon sutures, and they're fairly aggressive and fairly tight. I know this is going to cause significant corneal astigmatism putting these sutures in. However, you want a really watertight incision when you're doing the INA. And I know in the back of my mind that these sutures are going to come out, and the suture removal will reduce the corneal astigmatism. I go ahead and put the INA handpiece in, and you can see I have a very nice chamber. You can see there's a little bit of iris to the wound, but because I have 5 strong sutures in place, I'm able to still do the INA, removing any viscoelastic and remaining lens material. You can see the flopping of my anterior capsular rent, but again, the haptics are perpendicular to the rent, and the lens is perfectly centered and stable in the bag. I'm pulsing BSS and making sure there's no viscoelastic in the eye. I gently withdraw the INA handpiece with irrigation off to minimize any iris prolapse. And then I use my BSS cannula, push the iris back and reposit it so that it's not adherent to the cornea. I hydrate my incisions, and you can see I have a perfectly round iris. I have 5 very tight temporal sutures. You have a perfectly centered single piece acrylic lens in the bag with an anterior capsular rent. This patient had significant astigmatism, but with best correction, he was able to achieve 20/20. His other eye also has a cataract, not as big as this one, and he can already see post-op day 1 better out of this eye than his other eye. So again, this is displaying and demonstrating the ability to convert quickly to an extra cap technique. This is a case that had severe zonulopathy, a Morgagnian Catarock, as well as significant anterior capsule fibrosis. And I was able to leverage my M6 and extra cap techniques, utilizing a can opener, capsulotomy, widening my incision, and delivering the lens completely. So I hope this was helpful to you, and thank you for your attention.